want to pick one up on the way out, but it's really fun.
Great, thanks, Jessica. Okay, let's, without any further ado, get to the afternoon's main business. Thanks for coming along at lunchtime, an unusual time for us. Give me some feedback as to whether it works for you, better, worse, or different, because that's something people have been talking about. Anyway, so it's a real pleasure to have Hane Maung this afternoon. Currently at Lancaster, but about to move to University of Manchester to work on a project which is closely associated with what you're going to be talking about with this afternoon. So over to you, Hane, and thanks very much for coming.
Okay, well, thank you very much for the invitation. I'm delighted to be here with you today. So, this talk is on a project that I haven't yet begun, but I'm due to commence at the University of Manchester next month, as Alexander mentioned. So, I've called this talk, "Is Suicide a Psychiatric Problem?" to which my answer is going to be a very unhelpful no, because this is something that's still in the planning stage. So I'll be raising more questions in this talk than I'll be answering, but hopefully it'll stimulate some interesting discussion today.
Sorry.
Right. So of course, suicide's a topic that's inspired a lot of philosophical discussion, particularly in the continental tradition. This is Albert Camus, who's proclaiming that the only one truly serious philosophical problem is suicide. So while I share some of his enthusiasm, it surely isn't the only serious philosophical problem, but it is certainly philosophically serious. But as we shall see, I find it philosophically serious and interesting for quite different reasons. So the motivation for this project is there's tension between two ways of thinking about suicide in contemporary health discourse. So on the one hand, suicide is plausibly understood as a complex outcome of multiple interacting factors at multiple levels of organisation. On the other hand, suicide is often framed as being the causal outcome of mental disorder, and hence being predominantly a problem for psychiatry. So before I came into academic philosophy, I actually trained as a psychiatrist, and while suicide risk assessment and management was a significant part of the clinical duties of psychiatrists, so this is also the part of practice about which many psychiatrists felt most uncomfortable. So I think this framing of suicide as a causal outcome of mental disorder raises philosophical questions, some of which I'll touch on today. So there's an issue of causal complexity. How do we make sense of the messy and murky interactions of factors that are involved in suicide causation? Then there's also an issue of causal selection. So what accounts for our privileging of mental disorder over other factors as being the primary cause of suicide? And then there's also the issue of whether the connection between mental disorder and suicide is genuinely causal. Is it wholly causal, or is it partly the result of how we define mental disorder? So, just a bit of background. The World Health Organization reports that there are approximately 800,000 suicides each year globally, with about 5,000 occurring in the United Kingdom. It's also the second leading cause of death globally among people aged 15 to 29. And the World Health Organization considers suicide to be a public health priority, and specifically a mental health issue. So this, the tension between understanding suicide as a complex outcome, of multiple interacting factors, and on the other hand, the framing of suicide as the causal outcome of mental disorder is evident in the Department of Health's suicide prevention strategy in England. So the document acknowledges that suicide is the result of a complex history of risk factors and distressing events. However, it then goes on to say that suicide prevention begins with better mental health for all. And given that suicide is considered to be a causal outcome of mental disorder, psychiatrists are granted responsibilities for suicide risk assessment and prevention. So the American Psychiatric Association here considers suicide risk assessment to be a quintessential clinical judgment, whereas the Royal College of Psychiatrists in the United Kingdom suggests that trainees in psychiatry should be trained in suicide risk assessment and management from the first week. And furthermore, these duties are reinforced by the fact that mental health professionals and services can sometimes be held legally liable in cases of suicide. So here are just some media clippings from about psychiatric services and mental health professionals being sued or being held legally liable when people have committed suicide. So it's widely assumed as a truism that suicide is predominantly a causal outcome of mental disorder, and that accordingly it's a problem for psychiatry, or it's a problem for the mental health services. However, things aren't so simple, as there are many other factors that are crucial difference makers in suicide causation. And this is evidenced by the fact that most people diagnosed with mental disorders do not attempt suicide, and so the variance in the incidence of suicidality is also largely due to other factors beyond mental health diagnosis. Also, the rates of suicide in populations tends to vary independently from somewhat independently from the rates of mental disorders across these populations. So these suggest that mental disorder is certainly a contributory factor in suicide causation, but it's not a sufficient factor. So here are some of the factors that have been shown to significantly affect the risk of suicide. These are many of the difference makers. I won't read them out, but what you can see from this list is that there are diverse factors at different levels of organisation, including individual factors, historical and biographical events throughout the person's life, social and interpersonal circumstances, and aspects of the material environment. So, very diverse factors implicated in suicide causation. And furthermore, the interactions between the factors they're not simple linear causal interactions like this what we see there, where one event causes another and that goes on to cause another. Rather, as with all kind of complex intentional behaviours, the interactions between these factors are complex, they're dynamic, and they're reciprocal. Furthermore, these interactions cross different levels of organisation, such that, for example, individual factors are influenced by aspects of the social environment, and in turn, these social factors are themselves influenced by factors about individual psychology. So, given the multitude of factors and the complexity of these dynamic interactions, why do we privilege one factor? Why do we privilege mental disorder over these other factors as being the primary cause of suicide? And is this privileging of mental disorder justified? So more generally, we could ask the question: what distinguishes what we consider to be a triggering cause from what we consider to be a mere background condition? So we can turn to some philosophical theory on causation and causal selection to see whether it can shed any light on this issue. So some of the early literature on causal selection is rather sceptical and suggests that it's just arbitrary. So here's John Stuart Mill writing about the capricious manner in which we select from among the conditions that which we choose to denominate the cause. And then 140 years later, David Lewis, in his essay about causation, is also rather sceptical, stating that he's got nothing to say about the invidious discrimination of cause from various other conditions. So these seem to suggest that there's no clear rational basis for causal selection. So there's no rational basis for privileging one factor and saying that that's the cause, whereas the others are just background conditions. But I think before resigning ourselves to this sceptical position, I think it's worthwhile exploring some other hypotheses for why mental disorders are selected over other factors as cause of suicide. So one hypothesis is that mental disorder is selected as a cause because of the strength of the statistical association between it and suicide. So the psychological autopsy studies, which we'll say more about those later, but basically involve interviewing the friends and relatives of people who have died from suicide in order to ascertain the kind of circumstances surrounding the suicide and come up with some kind of causal explanation. So these psychological autopsy studies report the presence of mental disorder in approximately 90% of suicide cases. But it's unclear whether this, I think there are problems with this, because first of all, it's unclear whether this kind of statistical correlation is enough to justify causal selection. So to take an example from, so this is a paper by the philosophers Christopher Hitchcock and Joshua Noble, talk about the atmospheric oxygen is present in 100% of building fires, but lit cigarettes are only present in 10% of cases of building fires. But yet, in the case of the building fire, we consider, when we ask what had caused this building fire, we'd think of the lit cigarettes as being the cause, whereas we think of the presence of atmospheric oxygen as being a background condition. So, just it seems like just the fact that mental disorder is present in in the majority of cases of mental disorder doesn't seem enough to justify selecting that as a cause. Also, the other empirical evidence suggests that the statistical correlation between mental disorder and suicide may not be so strong, because even if we grant that mental disorder is present in 90% of cases of suicide, it is also the case that approximately 90% of cases of mental disorder do not result in suicide. So here, these considerations would be consistent with considering mental disorder to be a background condition, while other factors are the triggering causes that make the difference. So, for example, like the lit cigarette in the house fire case, if we think about 90% of suicides, in 90% of suicides, mental disorder is present, but yet in the population of people with mental disorders, only less than 10% result in suicide. So something else is making the difference rather than the presence of mental disorder. So it seems that statistical relevance isn't enough to account for our selection of mental disorder over other factors as the primary cause of suicide. So we need to explore whether this causal selection is influenced by other kinds of norm. So moving on to another hypothesis. So another hypothesis is that there's a pragmatic reason for selecting mental disorder as a primary cause of suicide. And this relates to issues about intervention and manipulability. So this draws on a fairly recent theory of causation developed by the philosopher James Woodward. It's called the Interventionist theory of causation. So in short, this claims that we can consider a variable C to be the cause of variable E if and only if a targeted intervention that changes the value of C also results in the change in the value of E. So let's take an example. So let's consider that there are 3 variables in the population that are correlated with each other. So let's say that the incidence of bronchitis, the incidence of tobacco smoking, and the incidence of lung cancer. So these 3 are correlated. And we want to establish whether there are causal relations between these variables. So what we can do, we can intervene on these variables and see what happens to the others. If we intervene on the bronchitis in such a way that decreases the incidence of bronchitis, but then the incidences of lung cancer and the incidence of smoking remain the same, then we can infer that bronchitis is neither a cause of smoking nor a cause of lung cancer, even though it's correlated with the 2. However, if we intervene on the smoking in such a way that it decreases the incidence of smoking in the population, and the result is that the incidences of bronchitis and lung cancer both decrease, then we can infer that smoking is both the cause of bronchitis and the cause of lung cancer. So there is also kind of a practical dimension to this, because in practice this depends on there being an appropriate kind of intervention. So we can make sense of the building fire case. So there's an appropriate intervention that decreases the number of lit cigarettes in buildings. So we might have appropriate legislation banning sort of smoking in public buildings, for example. And if this results in a decrease in the number of house fires, then we can say that, yes, the lit cigarettes are a cause of house fires. However, in practice, there isn't an appropriate intervention that can remove the oxygen from the atmosphere, so we'd be inclined to consider the presence of atmospheric oxygen a background condition rather than a triggering cause. But, so in the case of suicide, the problem is that it's far from clear whether the interventionist theory of causation can account for our selection of mental disorder as a primary cause of suicide. Despite the best efforts of psychiatrists, the evidence for the effectiveness of psychiatric intervention at decreasing the incidence of suicide in the population is quite limited. So the evidence for the impact of antidepressant treatment and suicide rate is notoriously equivocal, even though there is evidence that they improve depressive symptoms. There is some evidence, I mean, the strongest evidence for the effectiveness of psychiatric treatment for suicide prevention tend to concern highly specific treatments for small subsets of patients with specific diagnoses. So, for example, in a subset of patients with treatment-resistant schizophrenia that hasn't responded to 2 other antipsychotics, then the use of the antipsychotic clozapine has been shown to reduce suicide risk in that subset of patients. The same can be said for the use of lithium in some cases of bipolar disorder, and electroconvulsive therapy for some cases of severe treatment-resistant major depression, and dialectical behavior therapy for some patients who have been diagnosed with borderline personality disorder. However, these are very specific cases, and it's the impact of these treatments on the overall incidence of suicide is a lot weaker. By contrast, there's strong evidence that interventions on factors in the environment to reduce access to means for suicide can result in significant decreases in the incidence of suicide. So these include control of firearms, detoxification of motor vehicle gas, restrictions on toxic pesticides, and barriers on jump sites. So there was a famous example was the Clifton Suspension Bridge, when barriers were placed on the jump sites, the suicide rate in the Bristol area reduced significantly. So if we were to apply the interventionist theory of causation, there seems to be stronger support for the claim that suicide is caused by aspects of the enacted environment than for the claim that it's caused primarily by mental disorder. So again, we're left with the question of why suicide continues to be framed as being predominantly a problem for psychiatry. So perhaps Mill and Lewis are correct, and causal selection, at least in this case, is perhaps arbitrary. But even if we don't accept this, we need to be mindful, I think, at least be mindful of the hypothesis that the framing of suicide as being primarily a causal outcome of mental disorder is partly due to some contingent cultural and historical developments. This could be related to the rise of psychiatry as an epistemic authority throughout the 19th century, when psychopathology was often invoked in an attempt to explain a greater number of behaviours that were deemed somehow deviant or abnormal. So there's Esquirol in 1838, as early as 1838, proclaiming that suicide is an effect of disease. It could also be related to just the ways in which our institutions have been structured so that people in crisis exhibiting suicidal behaviours happen to be brought into contact with health professionals. So, for example, general practitioners and the emergency services tend to be some of the most accessible points of contact for people in crisis who are seeking help, regardless of the nature of the problem, which in turn sort of enable referrals to the mental health services. So it could partly be that suicide has become kind of discursively linked with mental disorder because society is structured in such a way that the health sector is the sector that suicidal individuals most readily access. So this bit is where I venture a little bit into the continental philosopher territory. We also need to be mindful of the possibility that the framing of suicide as a causal outcome of mental disorder is influenced by political incentives. So this concern is reflected in this tweet by the psychiatrist Louis Appleby, who's perhaps currently the leading suicide researcher in the United Kingdom today, and also a prolific user of Twitter as well. And if you're interested in this topic, I think I'd recommend following his account. Of course, so he's by no means an advocate of anti-psychiatry, but but even here he's challenging the kind of popular narrative that men have higher suicide rates than women because they internalise rather than externalise their depression. So his criticism here is that the narrative is framing suicide as a problem located in individual psychopathology, or the way that individual psychopathology is expressed, which in turn directs attention away from the need to address causal factors at social and environmental levels. So here he's saying, it lets society and government off the hook for tackling debt, alcohol, and loneliness. So the worry is that perhaps this framing could weaken the support for interventions that target these social factors and allowing the government to avoid responsibility for addressing social disadvantage and putting the responsibility for suicide prevention squarely on the mental health service. So far we've painted a quite a bleak picture so far, but there is another hypothesis about causal selection which I want to consider, although as we shall see, this as things stand, this doesn't make things sound much better. So this is the hypothesis that mental disorder is selected as a primary cause of suicide because it's the most proximal cause of suicide, while other factors are kind of distal causes. So what I mean by this is it's the idea that mental disorder is sometimes considered to be the final common pathway that leads to suicide. So according to this view, you've got various background conditions, addiction, poverty, mental illness, divorce, etc. And these are kind of distal causes that interact with each other, and they contribute to increasing the risk of suicide by contributing to the development of mental disorder, which in turn proximally causes suicide. So the idea that mental disorder is somehow the final common pathway that all these other factors contribute to, and then mental disorder eventually leads to suicide. Again, I think there are problems with this hypothesis. So the first problem is that the most proximal cause is not necessarily the most epistemically satisfying. It's often not the most explanatorily satisfying. So let's consider, for example, that a patient presents to a clinic, a general medicine clinic, with a cough, and the physician's task is to diagnose the cause of the cough, to work out what's causing it. So, of course, the most proximal cause of the cough is a neuronal reflex, because that's the final common pathway through which various possible clinical, like pathological processes. It's the pathway through which various kind of different pathological processes can produce the action of coughing. So, however, when asked what is the cause of the cough, neither the physician nor the patient would be satisfied by the explanation that, oh well, it's a neuronal reflex. It's caused by a neuronal reflex. Rather, the physician wants to ascertain whether this neuronal reflex is being distally caused by what kind of pathology is distally causing it. So is it a bronchitis that's triggering this neuronal reflex, which then results in cough? Is it a pneumonia? Is it asthma? Is it lung cancer? And so on. So here it's not the proximal cause, but one of the distal causes that's considered kind of the relevant cause of the cough. The other problem with the causal proximity hypothesis is that so the category mental disorder, we've got various factors, and they're all converging onto this category we call mental disorder. But the category of mental disorder is not a unitary kind. It's a highly heterogeneous category that encompasses all sorts of different psychological states, or all sorts of different possible psychological states. So, in other words, the category is more like a disjunction of many different possible psychological states, each of which is produced by various different combinations of interacting sort of distal factors. So this raises the worry that perhaps this category mental disorder, given that it's so heterogeneous, maybe it could be such a nebulous concept that it could be moulded to accommodate any kind of pre-suicidal psychological state that results from the interaction of various different causal factors. So, in other words, is it just this kind of concept of mental disorder being used as just a placeholder for whatever resultant psychological state happens to trigger suicide? So, the worry here then is that this raises the question of whether the connection between mental disorder and suicide is partly definitional. In other words, do we judge suicidal disorder to be disordered just by definition? And in fact, one scholar suggests that our normative conception of suicidal behaviour involves automatically attaching the label mentally ill to the suicidal behaviour. And there's some suicide researchers who actually consider suicidal behaviour to be an exemplar of psychopathology. And so it seems that perhaps the connection between mental disorder and suicide could partly be the result of suicidal behaviours being classified as a behaviour that indicates mental disorder. So to see why this is a problem, we can visit the philosopher David Hume, like I did with my little boy in this picture. So Hume famously argued that causal connections are contingent. So that's to say, an event C might have caused event E, but it's possible for C to have not caused E. So for example, let's take another medical example. We know that chronic smoking is a cause of lung cancer, but it's entirely possible for someone to be a chronic smoker and not develop lung cancer. By contrast, definitional connections are necessary. So given that lung cancer is defined by uncontrolled cell proliferation, it's not possible for someone to have lung cancer without having uncontrolled cell proliferation. If they don't have uncontrolled cell proliferation, then by definition, they don't have cancer. So that suggests that if the connection between suicidality and mental disorder is partly definitional, then then it can't be wholly causal. So what evidence is there to suggest that the connection between suicidality and mental disorder is partly definitional? Well, one reason is that suicidality is included in various forms in the definitional criteria for a number of psychiatric diagnoses. So here are some examples from the 5th edition of the Diagnostic and Statistical Manual of Mental Disorders, which is perhaps the leading classification system for psychiatric diagnoses. So suicidal thoughts and behaviours are among the criteria for at least 2 common diagnoses. So you've got major depressive disorder and borderline personality disorder. Furthermore, in the section in the manual on conditions for further study, there's a putative diagnostic category of suicidal behaviour disorder, which is considered. And this category encompasses cases of suicidal behaviour that are not ideologically motivated and which do not meet the criteria for other diagnoses. So this is just a putative diagnosis. It's in the section on conditions for further study. But it suggests that, that at least if this was to go ahead, it would suggest that the concept of mental disorder is perhaps being expanded to accommodate more and more cases of suicidal behaviour that wouldn't have previously fallen under a diagnosis. So, the tendency to consider suicidal behaviour as mentally disordered by definition is also reflected by the concept of masked depression. So here's Louis Appleby again. So here, Louis Appleby is talking about suicide victims who don't display any depressive symptoms or any symptoms of a diagnosable mental disorder, but who attempt or commit suicide following a sudden emotional crisis, often triggered by adverse events, rapid onset of despair, rather than sort of conventional depressive symptoms. So one high-profile case recently was that of Chester Bennington, who was the lead singer of the band Linkin Park. This photograph showed him just hours before he committed suicide. And his family had reported that in the hours and the days and weeks preceding his suicide, he was reported to have been happy, laughing, talking about the future. So there was no evidence of depressive symptoms. And a common reaction to this, and a common reaction to this story among the public was, oh, but if he took his life, he must have been depressed, really. He was just hiding it. He must have been depressed. So indeed, he was suggested to have been suffering from this this category, masked depression, which is the assumption of kind of a latent internal depressive state in the absence of outwardly manifesting depressive symptoms. So perhaps this could indicate as well the tendency to kind of consider suicidal behaviour to indicate mental disorder just by definition, and the expansion of the concept of mental disorder to accommodate more cases of suicide that wouldn't have met diagnostic criteria. So then there's also, we mentioned the psychological autopsy studies earlier on. I want to raise some worries about these as well. So, like I mentioned, the psychological autopsy studies, it's the method of interviewing friends and relatives of people who have died from suicide in order to clarify the circumstances surrounding the suicide and arrive at an explanation, a diagnosis. And these studies report, there's a systematic review which reported that these studies show the presence of mental disorder in around 90% of suicide cases. But but critics have reported some serious methodological problems with these studies. So there was quite a bit of work has been done by Heidi Gelmland and her colleagues in reporting confirmation bias in these psychological autopsy studies. For example, kind of interviewers may have been blind to the diagnosis, but they certainly were not blind to the fact that the person had died from suicide. The informants may have been seeking for kind of a meaning for the suicide, resulting in some hindsight bias, where past events are kind of reinterpreted to support their views about what must have caused the suicide. Also, the studies reported the systematic review. The studies also didn't take into account the fact that sexual abuse by a family member is a major contributing factor in suicide. And so if it happens that the informant in these studies was in one of these studies was the abuser, he or she may wish to attribute the suicide to a mental disorder rather than admit to the abuse. And also, the systematic review conspicuously dismissed a study from which looked at suicides in a different culture, and that the study actually demonstrated a low prevalence of mental disorder in cases of suicide. So, so then there's the worry that one commentator notes that if I hold to a belief that one has to be mentally disordered to die by suicide, I'm more likely to see and report symptoms that fit my beliefs, to worry about the confirmation bias. So, these considerations suggest that there's perhaps some circularity in the claim that mental disorder is a primary cause of suicide. On the one hand, suicide is judged to indicate mental disorder by definition. However, mental disorders also causally invoked to explain the suicidality. And they also suggest that the concept of mental disorder seems flexible enough to be expanded in order to accommodate more and more cases of suicide. So, to sum up so far, so I'm by no means an anti-psychiatrist. I think that mental disorder is clearly an important factor in suicide, and I think psychiatry has a crucial role to play in helping people suffering from suicidal ideation. However, the philosophical issues we've seen here do cast some doubt on the extent to which the framing of mental disorder as a primary cause of suicide can be sustained. So I think we need to proceed cautiously. So I want to finish just by briefly considering some potential implications of these problems for both for philosophy and for psychiatry. So with respect to philosophy, the issues regarding the nature of the connection between mental disorder and suicide could have implications for some of the theory in the metaphysics of causation. So as we've seen, the connection between mental disorder and suicide doesn't seem to be adequately captured by traditional philosophical accounts of causation. So it's not strongly supported by the interventionist theory, and it doesn't conform to Hume's dictum that causal connections are they have to be contingent. And there's the worry about perhaps this category of mental disorder may be too nebulous and heterogeneous to be considered a distinctive cause, or a distinctive kind of cause. So there are two possible responses to this, and I haven't quite made up my mind about which one I prefer. The first response is to bite the bullet and infer that mental disorder isn't a genuine cause, but that the connection between mental disorder and suicide is of a different kind. The second response is to infer that traditional accounts of causation don't exhaust all types of causation in the world. So if we are to take the second approach, then there's a question of how do we make sense of this looming, buzzing confusion of factors involved in suicide causation and the complexity of the relation between mental disorder and suicide. So perhaps we need to move away from this idea, this traditional view of causation as being a linear relation between distinct events that can be manipulated, that isolated out and manipulated. So rather, there's some work by the philosopher Sandra Mitchell, and she suggests that perhaps not just psychiatry, other biological sciences as well, but she talks about how we need a form of explanatory pluralism which considers causal relations to be complex, reciprocal and dynamic, and that also accepts causal relations that cross different levels of organisation. And she suggests that satisfactory explanations would need to integrate the findings of these different approaches. Right, so now on to, with respect to clinical implications for psychiatry. So I think acknowledging the limit to which this framing of suicide as being primarily a causal outcome of psychiatric disorder can support a call for the responsibility for suicide risk management to be shared between different appropriate sectors rather than being solely the responsibility of the mental health sector. At a policy level, I think this could fit in with a closer integration of suicide prevention policy with other public initiatives to tackle problems such as poverty, isolation, access to means of suicide, and other factors which are shown to have significant difference makers in the incidence of suicide. And at the level of the everyday clinical encounter, I wonder whether suicide risk assessment could benefit from a more narrative approach that might elicit causes, reasons, and factors beyond the diagnosis of a mental disorder. And finally, I think the recognition of this multifactorial and complex nature of suicide causation could encourage a system-level analysis of suicidal behaviour where the person's behaviour is understood in the context of his or her interactions with the broader interpersonal and material environment, rather than just an individual level analysis based on individual psychopathology. Okay, well, thank you very much for your generous attention. I'd just like to acknowledge that the Legal Human Trust, who are going to be providing me with support for this project over the next 4 years. Thank you.
Thank you very much, Hane. Now, we're going to take a small pause before the questions. I'm afraid we moved back to the room we were originally in, but we've had the presentation, so hopefully we won't necessarily depend upon that, because there are people who want to be in here, and they did offer to go in there, but there were people going in and out, and we'll just be sorry about that. But it's always good to stretch our legs. Okay.